on the disease process. So the more you understand the disease process, the better you'll be at actually coding them. We'll get in pretty in depth with specific diseases, and then I put in some commonly asked questions and the answer for us so that you can go back and refer to your slide deck and help you if there's something that you don't understand, like Hashimoto's disease, for example. You can go back and do a little more research on that particular disease process. We like to say as coding instructors that everything that you want to teach about diagnostic coding, ICD, you can do through diabetes, because most of the guidelines that are found in the ICD, they show up when referred to with diabetes. So we'll talk a lot about that, and I'll give you a heads up of things that you want to be aware of. Now, what are we going to talk about specifically? We're going to talk about how to correctly code our ICD and both CM and PCS. I'll give you a heads up on PCS as well. And we're going to also talk about the body systems involved with the endocrine, anything to do with nutrition and metabolic diseases. Just so you know, a little heads up, nutritional, malnutrition, stuff like that, gets overlooked a little bit. And so you want to bring up your knowledge base on nutritional and metabolic diseases, the things that you might not be aware of. A lot of us already know endocrine because of diabetes, and it's so commonly used as reference when teaching ICD. But there's some other things that again, we want you to be aware of. So let's start with diabetes, often abbreviated diabetes mellitus as DM. There are different types of diabetes. The two main types that are often referred to as type 1 and type 2 diabetes. In the past, they used to say type 1 was juvenile diabetes, but they don't really use that term anymore. They've kind of gotten away from that. They've also gotten away from using juvenile just as a descriptor for other diseases like juvenile rheumatoid arthritis, because juvenile diabetes is the same type of diabetes as type 1, whether you're an adult or a child, okay? And the misconception that comes with using the term juvenile is the fact that that's the only way that you can get it or have this particular disease, juvenile rheumatoid arthritis or type 1 diabetes, is if you're a child, and that just isn't true. So with rheumatoid arthritis, whether you have juvenile or just rheumatoid arthritis, it is still the same type of arthritis. Whether you have juvenile diabetes as a child or an adult, it's still the same type of diabetes. It just is commonly found in your childhood years because it's a congenital. And you really, very few times do you find a person being an adult diagnosed with type 1 diabetes that, because the side effects, the signs and symptoms are, much, I was starting to say harsh. They're not harsh. It's just that they can be life-threatening, and they're going to exhibit themselves very early in your life if you have type 1, whereas type 2 is not like that. So again, type 1, you're probably not going to see it documented as juvenile diabetes anymore. You might, but keep that in the back of your mind. It can show up and exhibit itself at any age. However, it is something that you're born with. The body is born that way, and you're going to show the signs and symptoms early. They do make a point to say usually before puberty, but I think a lot of times it's diagnosed even earlier than that, because we have so much knowledge about it, unless the patient doesn't actually go to the doctor. you know, but they're going to be a sickly child, put it that way. They have a specific guideline that is a default guideline that if we are not given in our documentation the type of diabetes that a patient has, type 1 or type 2, we default to type 2. And the reason we do that is because of the disease process. 95-98% of all diabetics are type 2 diabetics. And it goes back to other guidelines that you default. You know, if we have paralysis due to a CVA, we need to know what side is dominant, right or left dominance, because of the paralysis, you know, and the disease process and how we're going to treat the patient. Well, most people are right-hand dominant, so you default. The same way with type 2 diabetes. Most people are type 2 diabetics, and so you default to type 2. Can the documentation give us more information later and you change from type 1 to type 2? Absolutely. You always want to code to the highest specificity, but that is a note that you need to make for yourself because you will be tested on that. And it is something that you're going to find that you end up doing in the real world over and over again, because as much as we want to say that documentation is really, really good, there are times that we don't know. Even the provider doesn't know if the person's a type 1 or type 2 diabetic. And therefore, you know, we have to assume. But for the most part, you know, it is information that will be given in documentation. I have seen lots of documentation where it wasn't there and it was due to the provider's lack of documentation, but there are incidences like if a person comes in through the ER and we don't know if they're a type 1 or type 2 diabetic, and you can't just do a blood test to determine if they're a type 1 or type 2. The other thing that you need to be aware of with diabetes is that a type 1 diabetic requires insulin. That's just a given. So if you are a type 1 if you have a patient that's a type 1 diabetic, they will be on insulin. They will not be treated with oral hypoglycemics. It has to be insulin, right? Because their body does not produce insulin or enough insulin. Whereas with a type 2 diabetic, they have 3 forms of treatment. They could be diet and exercise to control their blood sugars. They could use oral hypoglycemics, you know, pills to regulate their blood sugar, or they could be on insulin. And that is why if you have a person come in and you know they're on insulin, you cannot assume they're a type 1 diabetic. Okay, so make a note of that. If it's not clearly documented, though, then you are going to default to type 2. There is also a Z code that you need to be aware of that states that the patient is using long-term insulin use or hypoglycemic drugs. Right? We've had for a long time long-term use of insulin, but here in the last few years we've been given also the Z code for oral hypoglycemic drugs. And we need to keep track of that. Remember, we are doing this for statistical purposes. So we are keeping track of how many people are on insulin, how many people are using their medications to control their blood sugars. And this changes the treatments of the future. So we want to make sure we capture that. Now, you also have a Z code for a temporary use of insulin to control blood sugar. Think about that. Why would you temporarily give somebody insulin? Maybe there was a trauma to the pancreas, and so therefore we needed to control their blood sugars. Patients who have open heart surgery, when they wake up, their body doesn't produce insulin properly. There's a little bit of a time period there where their blood sugars kind of trips them into a diabetic state. And usually before they leave the hospital, they can just, you know, regulate it with exercise and diet, but of course they're not going to be exercising much if they just had open heart surgery. So they'll put them on a diabetic diet for a while. They may give them oral hypoglycemic medications, and sometimes they might even have insulin, and it is a temporary use. Know the difference between long-term use and temporary use of the medication. Also, another form of diabetes is Gestational diabetes. This is not going to be an endocrine code, and it won't start with an E like E11 or E10 or E13. You're going to be using an O code to distinguish gestational diabetes. This is diabetes that only happens during pregnancy. It exhibits itself in the second trimester. That's why you'll often have your pregnant mamas go in the second trimester and have a glucose tolerance test. And then it could be treated if they develop this with diet and exercise. They may be given an oral hypoglycemic, and they may be using insulin. Once the baby's delivered, they no longer have gestational diabetes. If they have it one time in a pregnancy, they may not ever have it again, or they may have it with every pregnancy. But each pregnancy is different. So just because they get it once doesn't mean they'll get it again. But it is coded differently, and you need to be aware of that, because they will test you on this, and you're going to see this in the real world. All the guidelines for gestational diabetes are in the pregnancy chapter. Okay, so all of those O codes in the chapter for pregnancy, they will not be with the E codes, but you will be referenced back, and it'll say, there'll be an exclude. So it says, hey, if this is gestational diabetes, don't use this code. You need to go over and use the proper O code. There is also a code that you need to be familiar with, is one referring to use of an insulin pump and anything that happens because of the insulin pump. If you're not familiar with how an insulin pump works, I would jot that down in my notebook. I would go out and do a little research on that. Type 2 diabetics will use an insulin pump. And ultimately, there's more than one type, but what it does is it constantly checks the patient's blood sugar, and it is preloaded with insulin, and it will dose the body accordingly as the sugar goes up and down. And you may have heard of sliding scales for insulin use, and that's where, it states that if your blood sugar is, between 100 and 150, then you administer 1 cc of insulin. If it's 150 to 250, you're going to give yourself 2 cc's of insulin and stuff, and it directs you based on what your sugar level is as to how much insulin you administer. Well, the insulin pump kind of does that for you. So it's on the body at all times. It has the insulin preloaded, and it literally checks your blood sugar and injects the insulin as needed without you consciously knowing about it, more or less. The problem, though, is that it's a mechanical device, and things can go wrong. The tubing can get clogged. It can quit working. The battery can wear out. There's all kinds of things that could go wrong. And because of that, there is a complication. It would be a complication of insulin pump failure. Because it's taking the thinking away from you, it's like you take for granted, and you may not be aware that there's a clog in the tubing, and therefore you're not being dosed your insulin properly, and therefore you go into ketoacidosis, or you have a reaction. And that is a different code than if you were to code that the patient went into ketoacidosis. It was a direct result of the insulin pump. And why do we need to know that? Both for statistical purposes, as well as to know that the patient, wasn't a brittle diabetic, or there wasn't a problem that occurred with the endocrine system. It was the insulin pump that failed, not our treatment and how much insulin we administer. So again, it is underdosing of insulin, and there's also one for oral hypoglycemic drugs, where ultimately that is not the insulin pump that's doing that, but be aware that there is some other codes that go along with that. Additional codes that you need to be aware of, that deal with underdosing, go in and look at your DM codes and look under complications in your index, and that's where they'll be listed. You can also overdose on an insulin pump. Personally, I don't think this happens as much as underdosing, because if a complication happens with the insulin pump, that's usually what happens is the tubing is clogged. There's alarms and stuff like that happen, but it is possible to actually get too much insulin due to the insulin pump. And if that occurs, what you need to go do is look at T85.6 and also T38.3. Go look at those codes, become familiar with them, be aware that they exist, because sometimes your errors in coding is because you don't even realize there's a code for that. So make a note of that, and give yourself some annotation space around those codes if you need to give yourself a heads up about them. In addition, there are secondary diabetes that a person can get when they use insulin or hypoglycemic drugs. That Z code that I told you about, this is, you can also use it during that time, okay? So these codes will be Z codes. You're telling the rest of the story, right? We've got secondary diabetes, and we're going to use these medication, whether insulin or pills, as a result of that. If it's secondary, it's probably not long-term use, right? It's a temporary thing. Something happened to the body, corticosteroids or something was given, and we had to give them insulin for a little while, and then their body acclimates and gets back to normal. Another reason might be due to a pancreectomy. Now, they don't have to take out the entire pancreas, but they can take it out in portions. But there are codes for post-surgical hypoinsulinemia, meaning we did a pancreectomy and the body, because of the surgery, has low insulin. These are going to be E13 codes, so familiarize yourself with those. If you end up using this code, if that's the scenario, you will also assign a code for the fact that we have absence of a pancreas. These are status codes. All right. So why do we have hypoinsulinemia post-surgically? Because we took out the pancreas. Secondary diabetes due to medications. You'll often find that if a patient is given steroids or corticosteroids, that can affect the body. That's why if you have a patient who is a diabetic and they get a condition where they need a steroid, maybe they get pneumonia, that, we need to monitor the patient's blood sugars very carefully, because steroids and corticosteroids mess with your blood sugars, whether you are a diabetic or not. Okay, so because of that, we need to pay attention to the patients and the disease process in that scenario. Definitely, if a person came in with pneumonia and they're diabetic, we're going to want to make sure we capture that they're diabetic as well. The disease process changes in that incidence. Be very aware of the administering medications, poisonings, and sequela of poisonings, because a poisoning is where you are taking the medication and the body doesn't react well, whether it be a medication that we are prescribed and you're taking it correctly or not. You can poison the body, and that's what this is classified as. The body has a bad reaction to corticosteroids because you're diabetic and your blood sugar goes off the charts. Always, we're going to need to talk about the anatomy and physiology. So now that we've talked about the biggie, diabetes, let's talk about other things that happen with the endocrine system itself. Diabetes is probably that leading disease and disease process that we always associate with the endocrine system. If anybody says that they have an endocrine disorder, that's where your mind just automatically trips to, as some type of diabetes. That's the biggie. But there are other things that we need to be aware of. The endocrine system works with the nervous system, if you didn't know that. Actually, the endocrine system affects the entire body. It can affect every single body system. So in other words, you can't say a body system that it doesn't affect. The nervous system, that's why you have polyneuropathy in patients, nerve pain when they're diabetics. It affects your eyes. It affects your gastrointestinal. You can have gastroparesis with diabetes. You can also have integumentary issues. Definitely, there's just too much sugar in the body ultimately. And what happens in a warm, moist space with sugar, right? It breeds things that we don't want, that we already have in our body, that we don't need more. So again, there isn't a body system that is not affected because of the endocrine system. And there is more than diabetes that as far as a disease that it can affect the endocrine system, and we'll go over those. What does the endocrine system do? Well, the endocrine system also feeds our body, gives us our energy. We're able to move when we have a properly functioning endocrine system. When our endocrine system isn't working at peak levels, we're either going to be extra jittery or we're going to be extremely lethargic. It allows for homeostasis in the body. And stress can affect the endocrine system. It can also make you feel stressed and fidgety. The endocrine system is made up of glands throughout the body. Now, these glands produce the hormones that help our body function. That you may not be aware of it, but urinary output, also cellular metabolic rate is affected by the endocrine system, as well as growth and development. So if you see a person that is very small of stature, then one of the reasons that they may be that way is due to the way their endocrine system is set up, right? There is something that has happened to the endocrine system. So what you need to do is you need to ask yourself, what does the endocrine system do? Well, it maintains activities, hemostasis, and responds to stress. Where is the endocrine system? Well, it is all the glands that are in the body, and we have glands all over our body. We have glands next to our brain, the pituitary gland. We have glands in our throat, the thyroid glands. We have our hypothalamus. We have glands in the groin area. We have glands in all over our body. If you're not familiar with where the glands are in the body, then go out and Google that. Google image the glands of the body. What do they do for us? They secrete hormones. And hormones don't just give us our male and female sex genes. Hormones actually do a whole lot more. They give us our height and stature. If you have a tumor on a gland in your body that regulates your height, you can have megaly symptoms where your body doesn't stop growing. And then you can have the opposite where your body is very, very tiny and petite and small. So what's the result of the hormone production? Urinary output, cellular metabolic rate, growth and development. Those are the major ones, and you need to be familiar with that. And again, go out and study what the hormones do. We always think of estrogen and testosterone as what the hormones are doing for the body, but there are other hormones that affect the body. So the major endocrine glands are going to be the adrenal medulla, which is next to the kidneys, the pancreas, ovaries and testes. Of course, we think of that, right, for hormones. The thymus, a really overlooked gland, the pineal gland, anterior pituitary and posterior pituitary. These give us our height. thyroid gland, and I'm telling you, that little butterfly gland in your throat, if you have thyroid issues, it'll mess up the entire body too. Every body system will be affected by the thyroid gland. Parathyroid is those little pearls, the 4 little pearls that are on the thyroid, and they produce calcium in the body. And adrenal cortex. Go out, find where these are located, and memorize them. Okay. Endocrine diseases that you need to be aware of usually happen as a result of giving us a decrease or increase of hormone production. Now, if we have let's say a tumor or a neoplasm on the pituitary gland, what's it going to do? It's going to either make us a very tiny person or a very large person, right? Can they go in and they can remove that? Absolutely, they can. Changes in size of a gland can alter the hormone production. So whenever you have have you ever noticed when people go to the doctor, when you go to the doctor, they always palpate your throat here? You know, one thing they do, if they do this, they're palpating the carotid arteries. They want to see if those are bulging or, you know, have a nice rate and rhythm and everything. But if they do this, they're specifically looking at your thyroid gland. And if it's too small or too big, that can give a reason why you're having all these signs and symptoms and that you're not feeling well. Hyperplasia or hypertrophy of a gland. That means that you have a gland that's too large, or you can have a hypoplasia or atrophy, which means that the gland is too small. If you have a thyroid gland that is too large, you could develop a goiter, which we'll talk about some of those other things there. Other glands aren't as palpable as, you know, the thyroid. You can feel and physically see that that's an abnormal size, but you're not going to be able to see your pituitary or your adrenal glands. If you have changes in the gland, then you're going to have a hormonal dysfunction. Again, it affects every body system, from promoting infection, inflammation, not just in that area, but your integumentary system. You can get inflammations in your skin or on other organs. Radiation, trauma, and surgical procedures all will affect and cause hormones to and affect these glands and make them have a dysfunction. The signs and symptoms, well, we've already talked about growth abnormalities. A biggie is emotional disturbances. Now, if a person has hyperthyroid disease, they end up, the way I remember that, they are bird-like. They're very jittery. Their vital signs will be higher. They end up being a much smaller person. And I don't mean necessarily short, but their bodies are much more lean and thin. They don't carry body fat because the body is literally eating itself, is what it does. So that person will have difficulty sleeping. They still will have, they're very stressed and can have depression. And the opposite of that, having the low, is they end up retain fat. Their body doesn't feed off of itself properly. So you have issues of obesity, lethargic, sleepy, and not being able to maintain sleep, and being very depressed and having odd depressed thoughts that they know are not normal. So emotional disturbances, skin, hair, and nail changes. A lot of times you can look at a person's nails, and if you know they have an issue, it'll show up in the nails, whether they're brittle or not. The hair, when a person has hypothyroidism, they usually have baldness that isn't normal. Now, I'm not talking about male pattern baldness, but when you see women that have, you know, you can see their scalp, thin hair, that's a true sign of a major sign of having hypothyroidism. And the skin conditions will be, it'll be dry, Hypertension and hypotension, as you can imagine, if your body is revved up and speeding, you're going to have hypertension, and the opposite for hypotension. Cardiac arrhythmias is very common, and we're not talking about AFib. We're talking about the body's. You'll feel like your heart is always racing or trying to leap out of your chest, or it'll go, you're lub-dub, and then it'll kind of feel like it pauses. Muscle weakness and atrophy. So in other words, you just don't have strength that you should. And atrophy, the muscles kind of waste away. Impotence is very common as well. Changes in the libido. When you don't feel good and you don't have that, you'll have no sex drive. And infertility can be very common as well, because look, we're talking about hormones. So it all plays a part. So what happens when a person has endocrine disease? You're definitely going to have a change in hormone production. You'll either have more or not enough. There was a friend of our family's whose daughter had a beautiful singing voice. She was a soprano, and all of a sudden her voice started cracking and she wasn't able to sing anymore. Her voice was dropping, which they thought, not necessarily a big deal. It could be just strain on the voice and everything. Then she started having other issues where she had, she was getting hair at a very young age on her face. Come to find out, she was no longer having her cycles, and other issues that were not normal for a girl of her age. Ultimately, she had a tumor, and come to find out, she was producing massive amounts of testosterone. And once they removed the tumor, her body went back to normal, but she was literally turning into a boy because of the tumor. And so again, this is it's what happens. It affects the endocrine system and the hormone. What are your triggering factors that will alter hormone production? Very simple. Change in the size of the gland, whether it's too small or too large. And that can happen because of a cyst or a tumor, something happening, even trauma to that particular part of the endocrine system. So next, we're going to talk about the endocrine system as well as nutritional and metabolic diseases. Now let's break them up even more. A goiter happens to the thyroid. This is an enlargement of the thyroid. Now, if you've seen somebody that's had a goiter, sometimes they're in the center, sometimes they're in the side, or or off to the side. A lot of times they'll go in and they'll take that out. Maybe they don't have to take the entire thyroid, but if they do have to take the thyroid, then the person is going to be required to take thyroid medication. If you don't, then it can't regulate the hormones in the body. Sometimes a goiter will get so large that it's not just messing with the hormone production, it also makes it difficult to swallow or breathe because it's constricting. And these goiters can get extremely large. Of course, we're going to have hormone disturbances. Ultimately, one of the reasons that the person develops a goiter is that we don't have enough iodine in the diet. Now, let's talk about how that would happen. If you live on the coast and you eat a lot of fish, you're not going to probably have a problem with iodine in your system. But what if you're allergic to iodine? Then it's going to be a problem, right? And you don't usually see this as commonly in the United States because we have a very good diet in the United States. However, it does happen. My husband's grandmother had a goiter and ended up having it removed. There's just sometimes that it develops. It didn't have to do with her diet per se. Now, let's talk about the signs and symptoms of an endocrine disorder. We're going to have a different urine output, fatigue. We can have cycles that are not regular, and edema will be common problems. Hypothyroidism, then we're going to have a diminished production of the thyroid hormone. The signs and symptoms that are related there, we're going to have a low metabolic rate. We will the person will gain weight. A lot of times obesity is involved. Somnolence, meaning that sleep disturbances, they can fall asleep at any time. And myxedemia. And when that you have that ends up happening with the skin and tissue disorder. If you don't know what that is, it's a specific type of edema. Hashimoto's disease. If you aren't familiar with Hashimoto's disease, definitely write that down and go look it up. That is a result of inflammation of the thyroid. It often is a result of hypothyroidism. If the person has hypothyroidism, they can trip into Hashimoto's disease. It takes a long time to detect Hashimoto's disease, but so a person can have hypothyroidism and even be aware of it, and they'll be checked often to make sure it doesn't turn into Hashimoto's disease. Intolerance to cold is a big sign and symptoms to this. Of course, the weight gain, the fatigue, constipation is because the endocrine system affects every body system, and absolutely the gastro system and the digestive system, all parts of the digestive system. Also, they tend to always develop a goiter. If you have hyperthyroidism, it's almost the exact opposite. You can't regulate the amount of the pituitary system, the way it's producing the hormones. And this is, again, when you get the exact opposite of the low thyroid issues. It's the opposite. It's very fast and high secretions of the disease. So the goiter itself, it's just an enlarged thyroid gland. Sometimes it'll, your thyroid gland looks like a butterfly, and they can take out part, they can take out half, they can take out segments, but go in and look at thyroidectomies and how they do them and why they would take the whole thyroid versus just part. Also, you'll find that people that have thyroid issues it can run in the family. You can also have nodules or nodular goiters. So that's something that'll be documented that you'll see. The signs and symptoms, again, it can be harmful if we have problems breathing, but it can also affect the hormones. What are the causes? Usually lack of iodine, So my mother has thyroid issues, and her brother, who is a doctor, used to tell her, just put a little iodine in your water and drink it. Now, that isn't something that would be suggested for most people, but she believes in it. She'll even put iodine on her skin to help absorb it into the body because she believes that helps her thyroid. It's more rare in the United States, not only because of our diet, but we have iodized salt. In other words, the salt we use has iodine in it. Graves' disease. I think we see Graves' disease more than we see Hashimoto's, but this is associated with hyperthyroidism. It is an autoimmune response to the thyroid. Little bit different, right? When you got an autoimmune disorder happening, we have too much thyroid hormone, which is called thyroxine. This usually exhibits itself with people between their 20s and 40s. The signs and symptoms are almost the exact opposite of what we saw with Hashimoto's. They aren't able to sleep. They have sleep disturbances. Their heart is always racing. They have tremors in their hands and fingers. They literally shake. It's like, it's like being on speed. They sweat, more precipitation, not precipitation, it doesn't rain, perspiration, I can't even say that today. Sensitive to heat, whereas our other one was sensitive to cold, this is sensitivity to heat. They don't cycle their menstrual cycles. If they even have them, they're very light, and they tend to go to the bathroom, have bowel movements more often, because everything, even their digestive tract, is on overdrive. So hypothyroidism is diminished production of thyroid hormones, and everything is slow. Okay, think of that in the body. Whereas the opposite happens with hyperthyroidism. So myodexedemia is usually due to prolonged hypothyroidism. Go out and look and see how that exhibits itself. and somnolence. You will see that in documentation. Ultimately, people are able to sleep anywhere. They're always sleepy and drowsy. Have you had people that do that? Now, this can also just be because they have other reasons for sleep disturbance, right? Sleep apnea and things like that. But again, if a person is suffering from this, they're going to definitely check their thyroid to see if that's the cause. Graves' disease is other types of complications because of uh, the endocrine system. You can have Graves' ophthalmolopathy. Man, that's hard to say too. You can have X ophthalmolus. These are conditions I want you to go out and look and read a little bit more about, but be very aware of a thyroid storm. And you'll see that in the documentation, a storm. And this is a thyrotoxic crisis or storm. What happens is the body explodes. The endocrine system just goes crazy, and you'll get the intensification of all of the signs and symptoms. The patient will often run a fever, rapid pulse, and they can even have delirium when they have a thyroid storm. So again, know what Hashimoto's disease is and the signs and symptoms. Who's at risk of this particular endocrine system? With Hashimoto's, it tends to be women or people that have a thyroid disease in their family. It's not always detected earlier. It's not the first thing that you look at because it's a slow onset and it takes a long time to develop, but be aware of the signs and symptoms. Let's see, other signs and symptoms are listed here for Hashimoto's: dry skin, hair loss, heavy and irregular menses, and difficulty with concentration. Then hyperthyroidism, you're getting too much of the thyroid hormone, and it often is a result of something going on with the hypothalamic pituitary center in the body not working correctly. And it could be due to a tumor, neoplasm, or lesions. Disease condition, we've already talked about diabetes a little bit, but the thing that you need to be aware of, let's talk about them again a little more in depth. So for diabetes, with diabetes, you're not going to be able to absorb, and the body can't metabolize carbohydrates, protein, and fat. Ultimately, the endocrine system is, allows our body to feed. That's how we create energy, is we feed off the sugars in the body. And if the body cannot regulate how much sugar is in the body, then we're going to either have too much or we're not going to have enough to be able to feed our body and run the powerhouse, the energy source. So if we have insufficient production of insulin in the pancreas, because the pancreas does that for us, then we're going to have diabetes. Sometimes it's the cells themselves that are faulty, that don't work properly. We have type 1, type 2, and secondary diabetes. And there are some other terms that you need to be aware of, and I would write these down because you're going to see them in documentation. Inadequately controlled. You're going to see out of control or poorly controlled. Now, this does not mean that the person is not being compliant with their diabetic regimen that they've been given. This is meaning that the body is out of control, poorly controlled, or inadequately controlled diabetes. In other words, we're treating it, the patient's being compliant, but it's not working. Okay, so be very careful with that, because you will see documentation, and they'll do this for testing purposes, where they'll say that the patient's spouse states that the patient keeps Twinkies under their pillow or Snickers in their bedside table and sneaks, sneak sweets. That does not mean that they're poor control of their diabetes. It means they're not compliant. Okay, and they'll give you one of the poorly controlled in as one of the codes. Okay, and you have to understand there's a difference between that. Are they compliant, or is their body not working properly? Okay, that's where you'll get into things called brittle diabetes, right? And there's a code for that. In other words, they can't regulate it. It's up and down, up and down. Graves' disease, just tripping back in that, some of these questions know what Graves' disease is. It is actually the most common type of hyperthyroidism. It's an autoimmune response, and it affects the thyroid gland. What happens? We have an overproduction of thyroxine. They can test this with a blood test. Other signs and symptoms will be a goiter develops, anxiety, irritability, brittle hair, and weight loss is very common. These are very lean type people, but they have that willowy physique that is so common with the models and stuff. And I remember there was a nurse that I worked with at the hospital, and she had Graves' disease, and she was gorgeous, and she was willowy and beautiful, and she had Graves' disease very bad. And one person said in comment with another nurse, had said to them, "Man, I wish I had Graves' disease." And I remember that other nurse kind of getting upset with that person and saying, you should think about what you're saying, because Graves' disease is a horrible disease to have. Her body is literally eating itself. She can't have children. Yeah, she looks beautiful, but she can't gain weight. She has all of these things that are something that she deals with, and it's a very serious disease. And anyway, and I think it was because that particular nurse had gotten pregnant, and her friend couldn't get pregnant because she had Graves' disease. She was infertile. Okay, so just backtracking, and I don't mean to jump around a lot, but I put these questions in there because you need to know them, all right? The question and answers. Type 1 diabetes are always insulin dependent. They will always, always, always have insulin. It usually is found early in life, and what it means is the pancreas isn't working properly. It either doesn't work or isn't working properly. Type 2 diabetics may use insulin, but not always. Sometimes it could be diet and exercise. It can be part of the disease process through ethnicities. There are certain ethnicities that are prone to type 2 diabetes, like being Hispanic. They usually get it later in life. It's an adult onset. The pancreas works, but the insulin isn't metabolized. So the body is producing the insulin, but the insulin can't do its job. Okay. Whereas with type 1, the body's just not producing insulin. And again, type 2 is the most common, and that's why it's our default code. Just backtracking again, Graves' disease, what kind of complications can you have? You can have problems with the eyes. And one of the things with Graves' disease is bulging eyes. If you ever saw a person that has really prominent bulging eyes, they probably have Graves' disease. Complications are things, things we need to know about coding type 2 diabetes. And again, a person can have diabetes and Graves' disease. So that's why that's being iterated again. Type 1 versus type 2. If you have type 2, you could be treated with insulin. So you could have long-term insulin use code, that Z code. Now, if you have type 1, it's a given. You're on insulin. Would you code long-term insulin use for a type 1 diabetic? Yes, you can, but it's redundant because we know all type 1 diabetics use insulin, right? Will that be an acceptable answer? Type 1 diabetes E10.9 with long-term insulin use. Is that an acceptable coding scenario? Yes, it's acceptable. But even if the Z code for long-term insulin use isn't used with the E10, then it's fine. That's acceptable. However, type 2 E10.9, no, excuse me, E11.9 type 2 diabetes, if they're on long-term insulin use, you absolutely want to have that Z code appended, because we need to know that that type 2 diabetic is at a stage where they're using insulin. That is something we need to track. Children and adolescents still can get type 2 diabetes, especially with the fact that we have so much obesity in our children nowadays. So again, lifestyle and diet and exercise, we can have children and adolescents have type 2 diabetes. You may see it documented IDDM, insulin-dependent diabetes mellitus, and you might see non-insulin dependent diabetes mellitus. They have kind of gotten away from using these abbreviations because, again, people assume an IDDM is a type 1 diabetic, but that is not true, right? We know that. And NIDDM would be a type 2 diabetic. You can't be a type 1 and be an NIDDM. But that IDDM, just like I said, juvenile, because of the misconceptions that are associated with those abbreviations, they tend to not use them as much. But I see IDDM documented a lot in still. But don't assume just because a person is an IDDM, insulin-dependent diabetes mellitus, that they are a type 1 or a type 2, okay? Complications that are associated with diabetes, whether you're type 1 or type 2, any type of diabetes, even if your diabetes is the onset of something else happening in the body like trauma, it's going to affect the metabolic rate, and the manifestations are long. What you need to do is make a note for yourself, go in and look at your index, look up diabetes mellitus, and then look at everything that's listed underneath it. And that's a manifestation possibility. Even when you go to with, indent, in, all of those are manifestations that can happen due to diabetes. If you see the documentation due to, then you know that that is something that is a result of the diabetes. If it is in that drop down, if you see with and then you see it listed, we have there's a causal relationship, and we can assume that relationship in our in the documentation, whether it's documented or not. So if you have a person that has diabetes and CKD, we assume the relationship. Okay, their diabetes their chronic kidney disease is a result, a manifestation of their diabetes. The only time you do not assume that relationship is when the documentation state there is not a relationship because of that. So in other words, if you had a person that had CKD before they became diabetic, let's say they have an issue with their kidneys, and they have CKD, and then they turn 50 and they develop type 2 diabetes, and then the documentation may tell you that no, their CKD was established before their diabetes. Okay, you can't assume that it is not a relationship unless it's documented that it's not. You assume that it is. Okay, anything under diabetes mellitus that you see with and underneath that, you can assume that manifestation is part of that. Diabetes affects every single body system. Every single one of the body systems can have a manifestation, and there's combination codes to code for that. And we'll talk about that more in the coding. If there's no complications and no manifestations, then it's going to be E11.9 or E10.9, just regular old diabetes mellitus, type 1 or type 2. But you need to be very careful for things that might be a manifestation that you're not aware of, like metabolic complications, okay? Complications that are not with no specifications. If you're not sure, query the provider. Okay, that means, go ask your provider and say, can you educate me and let me know if this particular patient is a manifestation of their diabetes. Whenever you see the term with in the index, then again, you're going to see that as part of the manifestations, and you assume that relationship. It is going to affect the renal, which is your kidneys, ophthalmics, which is your eyes, neurological, which is your brain and nervous system, circulatory, everything to do with the heart and peripheral vascular system, and joints of skin. I mean, just that covers everything, right? But these are the, you'll see E11.2, and that'll tell you, is it a renal, ophthalmic, et cetera, et cetera. Do you have to have those memorized? No. If you do have the character behind the point memorized, what the manifestation is, it'll make you faster, but a better coder. But it's all right there in the documentation, or excuse me, in your manual. You don't have to have it memorized. Common kidney complications with diabetes, CKD being one of the major ones. It's listed under renal manifestations. If a patient has CKD and hypertension, you're going to end up using 3 codes. Okay. CKD and hypertension has a causal relationship. If a person has chronic hypertension, then they're probably going to have something wrong with their kidneys. If they have something wrong with their kidneys like CKD, it's almost a given they're going to have a hypertension. Retinopathy. There are different types of retinopathy, and we want to always get to the highest specificity. But retinopathy is common with patients that have diabetes. The eyes are very quickly affected with diabetes, as well as neuropathy, which is going to give you pain in the central nervous system. Excuse me, the peripheral nervous system. Whenever you code with neuropathy, your 5th character is going to identify what type of neuropathy it has. So if you have a patient that has a metabolic complication and there's no additional manifestations, what do? You're going to go look at the metabolic complication, and then you're not, you don't have to code any other codes with that because there's not a manifestation. If you're not sure, then query the provider. Coding tips that you need to be aware of. Diabetes has a lot of combo codes. Just because there's a combo code doesn't mean you may not have to use additional codes. If you have CKD with diabetes, then you're going to code the combo code for diabetes with renal manifestation. You're going to code the CKD code because they need to tell them, well, if they've got a renal manifestation, what is it? Well, it's CKD. Okay, well, if it's CKD, what stage CKD? Well, it's CKD 4, so stage 4. So that's N18.4. And then, so you've given yourself 2 codes. And then if the patient's on insulin, you might have a Z code, long-term insulin use. The guidelines are right there. Not only are they in the guidelines section of your manual, but they're right there surrounding the E11 codes and the E10 codes. They're all right there. So you don't have to have them memorized. Just be aware that you're going to end up with manifestation codes, even though there is a combo code that tells you that the person has a renal manifestation as well as diabetes and a renal manifestation. There, you need to identify what the manifestation is to a higher specificity, and always be very careful with conflicting information, and you can always query the provider if you need to. If there's any complications as a result of a manifestation, then you're going to end up coding that as well. Remember, we already talked about the Z codes for an insulin pump. And again, it's usually, if your person has an insulin pump, they're usually a type 1 diabetic, okay? The guidelines will tell you what to do. We also have secondary diabetes. So we have type 1, type 2, and we have secondary diabetes. What does secondary mean? Well, the diabetes is caused by something else happening in the body, and it's usually a temporary thing. It's another disease that has happened to the body, and it's treatable, right? So steroid-induced diabetes. I already told you that steroids and corticosteroids can trip the body into having insulin issues, because what happens when we put the body on steroids? It makes the body insulin resistant. The pancreas cannot be making enough insulin temporarily due to a tumor, cancer, or a decrease of the pancreas being part of the pancreas being removed. When the person has been on steroids and then we stop the steroids, that's a problem. But then the person may or may not continue to have diabetes. So be very, very careful with those risk factors. Hypoglycemia, you have glucose or blood sugar that's really abnormally low. Is this diabetes? No, it's not. Can a person with diabetes be tripped into hypoglycemia? Absolutely, the person can. It actually is very common to have a diabetic do that. So you have you're diabetic, your sugar goes way up and then it bottoms out. Okay, just as much of a problem as if their sugar is running high. So normal blood sugars end up being 70 to 99 when you test them. So when you get into 120s, then you're like, we're starting to get some issues there. You know, anything above that, they're going to start having you check your blood sugars and to see, is there certain times of the day, before eating, fasting, things like that. And because if your sugars are running high, whether you're diabetic or not, then it's going to cause complications in the body. You've got too much sugar in the body. And if your sugar is running low, you've got something wrong there. We need to see what's happening. Hyperglycemia. Can you have hyperglycemia temporarily? That's not part of diabetes. Yes, but long-term hyperglycemia happens in diabetics. Okay, so don't get it confused. Hyperglycemia confused with being diabetic, because you can have hyperglycemia when you're diabetic. You can also have hyperglycemia when you're not diabetic. What it means is the body is running too high, of abnormally high blood sugars. Steroids can cause hyperglycemia. So we have E10 for type 1 diabetes. We have E11 for type 2 diabetes. And then we have a code for secondary diabetes. Don't get those confused. You'll be tested on those. Hypoparathyroidism. Well, this is when the parathyroids are not working properly. They're not producing enough calcium, ultimately, is what happens. And this can affect the entire body. What do we need calcium for? Well, our bones, right? If we run hypoparathyroidism, then we're going to end up having bones that aren't strong enough. And then we can also have what? Osteoporosis. Calcium is used for our heart. So our heart is muscular, it's also electrical, but it's also chemical. And we need calcium for our heart to run properly. We also need potassium. If we don't have enough calcium in our body, then we'll have heart palpitations and spasms in our muscles, which is called tetany. Hypoglycemia in diabetic patients can cause muscle spasms like this, and heart palpitations. The circulatory system is affected. The opposite of this is hyperparathyroidism. Now, I actually have hyperparathyroidism, and the reason I have it isn't because of my parathyroids. It is because of my kidneys. My kidneys spill calcium. They let calcium fall out of my body at too rapid of a rate, and therefore the manifestation of that is hyperparathyroidism. So my parathyroids produce excess amount of calcium, and that is got some positives. I have never had a cavity, and I have great bone density, but I also have kidney stones a lot, and that's a problematic. So I can have my hyperparathyroidism as a result of my kidneys treated and take out my parathyroids, but or I can take medication that helps with that. So what happens? Those little pearls in your thyroid produce too much calcium. Also, this can cause problems because your circulatory system, the circulating of calcium throughout the body not only affects the bones, but it also affects the amount of calcium in your heart, right? So just as bad having too much calcium for your heart, too little, right? Both is a problem. You can also run into hyperglycemia when you have steroid-induced diabetes, and hyperparathyroidism can be an effect of that. Hyperpituitarism, which means that we have a problem with the human growth hormone, and you'll see this abbreviated as a little HGH, capital GH. If we have increased production of pituitary hormones, then you're going to get giantism. So people that are very extremely tall. Now, there's a difference between just being hereditarily tall and having giantism. Also, there is acromegaly, which affects the pituitary, and with acromegaly, you'll see the jaw continues to grow, the bones continue to grow abnormality. Whereas a person has giantism, their long bones just keep growing, but everything's in proportion. Whereas with acromegaly, things aren't in proportion, and again, a very strong, massive jaw, both in women and in men, and the body never stops growing. Okay, the bones never stop growing. So the older you are, the bigger you get. Nothing stops it unless you have whatever's causing the pituitary gland to secrete so much, which is usually some type of a tumor or something. If that's not removed, then you just keep growing. Pituitary adenoma is usually the most common cause of this. So people like Andre the Giant, he had that. He had acromegaly, not just giantism, he had acromegaly, and you can see that with his jaw. Hypopituitarism is the exact opposite. We don't have enough pituitary glands, so we have a very small stature, tiny people. The exact opposite. Diabetes insipidus. This is called water diabetes. Ultimately, the body's release of vasopressin is a posterior pituitary gland issue. The signs and symptoms is thirst, fatigue, and dehydration. There is usually an underlying cause for diabetes insipidus, and there's a different code for that. So backtracking, hyperpituitarism, you can get giantism, and acromegaly can occur. If you have giantism, the hormone, the HGH, is hypersensitive before pituitary. Clinically, what is happening is it's not proportionalized. You have overgrowth of the long bones, but acromegaly, you have overgrowth of all of the bones. In acromegaly, you have the hypersecretion again, happens after puberty. So see the difference? And you'll see it very evident in the face, the hands, and the feet, and soft tissue overgrowth. So like the ears will be huge, things like that. What's the cause? Usually pituitary adenoma. And if they can go in and get that neoplasm, it'll stop, but it won't regress. Once the body's hit that stage, that size, it won't make the body won't revert to a smaller size. Cushing's syndrome. This is excessive circulatory cortisol levels. This is a hypersecretion of the adrenal cortex. What ends up being your signs and symptoms? You got fatigue, muscle weakness, a moon face. The face is very round and pudgy cheeks, hypertension, and edema throughout the body. You can have iatrogenic Cushing's, and that is called Cushingoid, may be used with the OID. So in other words, treatment induced that. Let's see, this is just talking a little bit more. I think the slide got out of sequence for hypopituitarism, affecting the pituitary gland, the immune system, and metabolic diseases. You can have sarcoidosis and histiocytosis X and hemochromatosis. So what's the effect? Well, the hormones secreted by the pituitary gland affect the function of the gland itself. You don't have enough TSH in the thyroid gland. If you have hypopituitarism, then you can have tumor, head trauma, brain surgery, stroke, and infections can all trip the body into hypopituitarism. Addison's disease, adrenocortical insufficiency is what happens here. So again, this is the adrenal gland. Usually it's caused by a neoplasm, some type of cancer. It can be surgically removed. They just take out the adrenal gland. It's an autoimmune process. Tuberculosis can cause this. You can have hemorrhage or infections that can cause this. Your signs and symptoms that you're going to see with Addison's disease is hypotension, weight loss, anorexia, they just have no desire to eat, weakness, and bronze skin coloring. That's very common. Go out and look at images of people that have that, and you'll notice that. When you have that diabetic insipidus, you may see that as it's unrelated to diabetes mellitus. So what happens is you have the patient has diluted urine. There's no color to the urine. Other signs and symptoms, again, we already talked about, very thirsty, fatigue, dehydration, but usually they treat that because they figure out what's causing the underlying, it's an underlying condition, and they treat that, and then the diabetes insipidus goes away. Now we're going to move into malnutrition. This is a nutritional disorder. I think it's a lot of time overlooked, and you forget that you have codes for this. What ultimately is the primary cause? Well, we have deprivation of protein energy, which can be caused by several things. Poverty, self-imposed starvation. So you've got anorexia or anorexia nervosa, bulimia. You could have secondary deficiency diseases. Maybe we have a type of cancer in the gastrointestinal tract that is causing malnutrition. Signs and symptoms, we're going to have things like diarrhea, skin lesions as a result of malnutrition, loss of hair, poor nails, very brittle nails that don't grow, and edema. The body is trying to maintain. Let's see, this goes back to the previous slide. I'm not going to talk about this because it's just out of place, and that's talking about Cushing's again. We're stick with malnutrition. Complications, muscle wasting. So it's not just atrophy, the muscle is wasting away. Why? Because the body has to feed on something. If there's no fat and there's no sugar in the system, because we're not eating properly and the body isn't absorbing the nutrition through the small intestine, it's got to eat something, so it'll start eating muscle. Enlarged glands, because the glands are working overtime, and you can have hepatomegaly, which is meaning the liver is enlarged. The liver is trying to produce more blood cells. How do we test this? Usually we can find out because of lab results, blood and urine tests, and they're going to show all these abnormalities in the body. Let's see. This talks a little bit about the signs and symptoms: hypotension, weight loss, anorexia, weakness, and bronzing of the skin. Emotional disturbances can be a cause, depression, anxiety, but usually the patient's seen for dehydration. That's one of the first things, and there's an electrical imbalance, and then everything else just kind of falls into place, and you see what's happening if there isn't a disease process involved. Moving into some vitamin deficiencies. These are E codes, but look at all the different types of vitamin deficiencies. We have vitamin A deficiency. We have thiamine and niacin deficiencies. That's going to be E51 through E52. These are mostly E5 codes, but notice down at the bottom, other nutritional deficiencies is E63. Deficiency of B complex components. Now, different disease processes, and also just getting older will cause a patient to become vitamin B deficient. You'll have vitamin B12 shots. I just gave myself yesterday my vitamin B12 shot. After you have any type of gastric surgery, you probably will end up with B12 shots. Since I had gastric sleeve done for weight loss, I now have to have every month a vitamin B12 shot because my body just doesn't have enough vitamin B, and it's not fun to get low on vitamin B12. You become very lethargic. E53 is going to be deficiency in the B complex. Ascorbic acid deficiency, vitamin D deficiency are all ones that you should be aware of. Anemias are not in this area, by the way. Anemia has its own area of coding. Anemia, go look in the index and see how many pages you have for descriptions of anemia. Okay, I'll just skip over that. Other vitamin deficiencies would be classified under what's causing the deficiency. Digestive tract disorders. Is it a lifestyle issue? Is it a chronic illness? Or is it the patient's age? And again, like I said, our geriatric patients often have vitamin deficiencies. Why? Because the digestive tract is just wearing out. It slows down with age. So look for other diagnoses that could be a cause or that need to be documented or is documented, and you need to capture it. Vitamin deficiencies, these are very commonly overlooked and missed as far as a code. Some deficiencies are named specifically. Okay, so how do they treat malnutrition? Well, the underlying cause ultimately is, is our patient malnutrition because of their age? Then we're going to have them start supplementing with Ensure. Is there a chronic illness that's causing the malnutrition? Is there a lifestyle issue? Did they move to a different side of the country? Did they become vegan? Did do they have a digestive tract disorder? Do they have IBS, for example? Obesity definitely is something that is overlooked in the coding. You want to make sure that you capture BMIs. The BMI code is, if it is listed, the patient's BMI, you can code the BMI if obesity is listed, okay, or extreme low weight, the opposite of obesity. But you can't just code the BMI just because it's listed. You'll often find the BMI located in documentation up by the vital signs, and it's okay to capture the BMI if the nurse or a clinician documents the BMI. That's an exception to the rule. But again, obesity has to be listed, or some type of malnutrition as a result of low BMI. The Z code is used with obesity, and you can have pediatric and adult BMIs. So don't forget to capture that if it's there. But you can't code a BMI just because the BMI is listed. It has to be an abnormal BMI, too low or too high. Okay, and so you have to have obesity documented as well. Morbid obesity is a patient that's 50 to 100% over their ideal weight, or 100 pounds over their ideal weight. It would be listed as morbid obesity in the documentation by the provider. This means they're going to have a BMI over 40, and that also means that it risk adjusts if you end up doing risk adjustment coding. Complications. Diabetes, one of the number one things that morbid obesity causes is diabetes, hypertension, heart disease, and stroke. So these are all complications of obesity. Some other vitamin deficiencies will just make a note for yourself that if the body is not absorbing nutrients, just pay attention as to the reason why. Again, is it IBS, or is it, because the patient is not bringing in enough protein because they are on a vegan diet? And you can get, a vegan diet is not a bad thing, but maybe when a person has just started the vegan diet or a vegan lifestyle and they're still learning how to get the proper protein into their system, then it could be a problem. We don't usually have vitamin C deficiencies or scurvy in the United States because everything is supplemented with vitamin C and D, the milk, the orange juice, everything. And so keep note of that. We have fruits as well. Hypervitaminosis. What is this? Well, we end up getting a toxicity result because we got too much of a vitamin. Some people think just because it's over the counter, it's okay to take, but that's not actually true. We can actually poison ourselves by taking too much. I remember when I first started taking my B12 shots, and I was still regulating, my system, and I was still really, really tired. And about 2 weeks before I needed to get my B12 shot, I would get really, really tired and lethargic. And I said, "Can I have 2 B12 shots?" "No, you can't. You get too much in your system." Fat soluble vitamins A, D, and K are ones to look for. You don't want to overdo those because they result in poisoning, and that would change the way we would code them because they're a poisoning. Another disease that we need to be aware of for this body system is cystic fibrosis, or CF. It's actually a genetic condition. That means that if it's in your family, they want to know that. It changes the way our cells produce mucus, sweat, saliva, and digestive juices. Think about where the mucosous membranes are in the body, not just in the mouth, but also around our lungs, right? So cystic fibrosis will affect people that through their lungs, that will fill their lungs up with fluid. Passageways, things like the pancreas and the lungs get clogged up, as well as the manifestations as a result of cystic fibrosis. That means your pancreas isn't going to work as well. But a lot of times cystic fibrosis affects the lungs, and that's where you'll see they'll go in and they'll pound the lungs and give them treatments to help suck out the fluid in the lungs. Complications of cystic fibrosis are going to be pneumonia, bronchitis, bronchiectasis, and asthma will be complications of cystic fibrosis. Just another note about your BMI codes. Underweight is below 18.5, healthy 18.5 to 24.9, overweight is 25 and up 29 of a BMI, and anything above 30 is obese, and anything above 40 is morbid obesity, by the way. Jumping in, cystic fibrosis again, risk of pneumonia. Look for cystic fibrosis with pneumonia, and then we need to know what is the organism due to, will be in there. You don't usually get these type of pneumonias with people that are healthy. Cystic fibrosis makes you more susceptible to common infective organisms. Organisms may be present. So it doesn't mean that the patient has pneumonia or Pseudomonas unless it's stated as Pseudomonas. If it's related to the CF, it needs to be it's documented that way. That's the way you're going to code it. Coding rules that are associated that is look for complications of cystic fibrosis. So go look up cystic fibrosis in your index, then look at complications and pay attention to the complications that are in there. These would make your diagnosis is the principal diagnosis, and cystic fibrosis is the secondary diagnosis. Why do they have this? Because they have cystic fibrosis. Manifestation codes would be pulmonary manifestations, gastrointestinal manifestations, and you could have both, because wherever you have mucus or saliva involved, then you're going to have an over excess of it. Just a little more information about vitamins A, K, and D. Metabolic immune disorders. What is evolemia? It is a state of normal body fluid. Yay! Everything is in good shape. But if you have, it's volulemia, by the way. If you have too Boyd, let me know as soon as I'm back on.
Yep, you came back just now.
Right away? Okay.
Back up
I'm going
30
back to slide
seconds.
32. Okay. Let me go back to
Camera's still not with me though.
Okay. I'll turn it off and turn it back on if I need to.
Okay, I'm seeing the home screen now.
I'm so glad it didn't dump the whole turn off completely.
Did you get a notice or something?
No, I didn't. All of a sudden that other screen just popped up. Usually it tells me and I get a blue screen.
Gotcha.
Okay. So, okay, I'm on this slide. I'll turn my camera off and is my camera back?
Yep, you're back.
Okay.
Grace,
I'm just going to back up to this slide again. So other metabolic and immunity disorders that we can have is the problems with the volume of fluid. If we have euvolemia, that means everything's good. Everything's copacetic in the body, right amount of fluid. If we have hypervolemia, we have fluid overload, and you'll see fluid overload written sometimes, or it'll say hypervolemia. Either one you'll see in the documentation. This can happen if a person's had too much sodium intake, especially if they have cardiac issues, but it also can happen when you have IVs. Or side effects of medication. So when one of my children was born, I remember I asked for more IV fluid because my milk doesn't come in very good. So I would I asked for more IV fluid. Well, sure enough, they gave me more IV, and then I had sausage fingers for a little while. I had gotten too much fluid in my body. But usually this happens as a side effect of some type of heart failure, like CHF. You'll see hypervolemia very commonly with CHF and edema. Hypovolemia is decreased plasma volume. Plasma volume. That's different than just regular fluid in the body. Okay. It's not the same as dehydration. So here's a little more information about cystic fibrosis that you can look at. Other metabolic and immune disorders, dehydration and volume depletion, two different things. Okay. So dehydration is what happens because we don't have enough water or fluid in the body. And that can be from us just not drinking enough, or it can be the side effect of having chemo treatments, nausea and vomiting, medications that we take. So I take HCTZ, which is an old-fashioned water pill, because I have kidneys that spill calcium, right? So I have to keep my kidneys flushed. Well, a very common side effect, because I have to take such a very strong or very high dose of that, is dehydration. So I have to be very, very conscious if I don't drink enough. Thus, I always have a water bottle around me. I get dehydrated. Dehydration causes all kinds of problems like lethargy and palpitations of the heart and stuff like that. Ultimately, you just don't have enough fluid in the body for the body to work at peak volume. Now, volume depletion is either because we had dehydration or hypovolemia. Something else is happening in the body that we don't have enough plasma. Okay. Metabolic and immunity disorders, neoplasm guidelines are going to be very specific here. It's dehydration is a very common reason why a person is put inpatient, okay? But we don't just get dehydration for no reason. So they may be admitted due to the dehydration, but what's the underlying cause of the dehydration? If it's due to a malignancy or the treatment of the malignancy, there are specific guidelines and the coding sequencing changes. You need to be very aware of that. So go and look at dehydration in the index and pay attention, and then what it says there, and go look at it in the tabular. Malignancies are always secondary in this case. So if we're admitted for dehydration due to a malignancy, the dehydration is coded first and the malignancy is coded second. If you have severe dehydration and it results in acute renal failure, the acute renal failure is the reason why the patient's admitted, then the dehydration, and then what actually caused that. Tumor lysis syndrome, you may not have ever heard of that, but it is a problem with the electrolyte and metabolic process, and it is a breakdown of dying cancer cells ultimately. So you can have hyperkalemia, which is vitamin K, hyperpotassemia. No, that's phosphatemia, not potassium. Kalemia is potassium. Hyperuricemia, hyperuricosuriasia, and hypocalcemia. Those are all ones that are too much of those, or hypocalcemia, meaning too low calcium. The signs and symptoms are nausea, vomiting, shortness of breath, irregular heartbeat, lethargy, cloudy urine, and joint discomfort. So again, look for those in the documentation. What ends up causing this? A lot of times it has to do with the kidneys, acute kidney failure, arrhythmias. Seizures can cause this. If something happens and you have loss of muscle control, and you can have death as a result of this if it's untreated. So be very careful in paying attention to the documentation on that. Just going back to dehydration, here's some codes for you to be aware of for your dehydration, E codes. Dysmetabolic syndrome X, this is abdominal obesity. So the person will have spindly legs and arms, but their abdomen will be huge. They're usually insulin resistant. They have dyslipidemia, so there is an in proportion of the fats in the body, and hypertension. When people have type 2 diabetes, they're at a greater risk. They have cardiovascular disease and stroke. You're going to end up having to code all of the associated manifestations as well. Now, we're going to talk about some Z codes that you need to identify. Whenever you are dealing with the endocrine system, the Z codes that you need to be aware of are going to be personal history and family history. Don't get them confused. Special screenings for. So we're doing a special screening for diabetes. We're doing a special screening for hyperthyroidism. Dietary surveillance and counseling. We have a patient with anorexia nervosa, and we're going to do counseling. We're going to put them in-house, and we're going to do dietary surveillance for them and counseling. We have a high or low BMI for both adult and children. Those are all carry Z codes. Surgical treatments that you need to be aware of. If we have a goiter, we're going to go in and remove the goiter. You're going to treat hyperthyroidism or Graves' disease with surgery. Hyperpituitarism, we're going to go in and go get whatever's causing that, usually some type of a neoplasm. Same as hypopituitarism and Cushing's syndrome. We're going to end up doing some type of surgical procedure. If we do radioactive iodine, usually we're treating a goiter or Graves' disease. Other names for that syndrome X is here that you might see obesity syndrome. Nutrients and vitamins, malnutrition, vitamin deficiencies, and hypokalemia will all be under nutrient and vitamins. If we are dealing with radiation, it's usually to treat hyperpituitarism if it's not for like cancer treatment. Diet, exercise, and behavioral modifications can help with all of the diseases that we've talked about, but especially diabetes type 2. Our PCS codes, we're going to look in the gastrointestinal system, the hepatobiliary system, and pancreas. which will be the liver and the pancreas. Endocrine system, those are the body systems that we'll be looking as procedures to work on with the diseases we talked about today. They're also bariatric procedures that we might be doing. This is usually dealing with obesity or related diseases to obesity. The 4 common ones are a BPD, which is a biliopancreatic diversion, which doesn't have to do with weight loss surgery, and called an R&Y or a Roux-en-Y gastric bypass, adjustable gastric banding, as well as vertical sleeve gastrectomy. That's the one that I actually had, the last one. Also, there's procedures with insulin pumps. Now, I already talked about insulin pumps and what they were, but you can have procedures. We've got to put them in. They actually are. They put in a little place for you to plug those into your system, and they're usually somewhere in the abdominal area. It's a continuous drip of insulin throughout the day, and the patient can do it, or the insulin pump can do it by itself. It depends what type you have. Okay, so there's all kinds of levels. They're very expensive. Medicare pays for some and they don't pay for others, et cetera, et cetera. And I leave you with this very long lecture, knowing all of life is a constant education, by Eleanor Roosevelt. Why is this pertinent? Because when you are doing something like a coding career, changing careers maybe, think about all of the exposure that you've had, or people that you know, loved ones, or yourself that has had or been associated with these disease processes. Your knowledge of just a friend that has type 1 diabetes, or a family member that's hyperthyroidism, all of that knowledge that you get from them is increasing your knowledge base and making you more aware and a better coder. So the sicker you are, the better coder you are. That's not nice to say, is it? So if you have any questions, don't forget, you can ask them in the club. If you're joining us on Facebook or YouTube, don't forget to like and subscribe, and go check out the club where you can get your questions answered just like that, and see more lectures like this whenever you need them. All right. Bye, guys. Thank you.